Great. Okay, so this session is now being recorded. Welcome, everybody. I know that some people are still joining, but I'm here today to provide you with an overview of the Somerset Safeguarding Adult Board, Safeguarding Adult Reviews Learning that has been completed within the past year, so from 2025. My name is Julia Mason, and I'm the designated nurse for safeguarding adults in the NHS Somerset ICB, and I also chair the Safeguarding Adult Board Learning and Development subgroup, of which this webinar was agreed to be a task to undertake. So what I'm going to do this morning, or rather this afternoon, is just run through quite a long list of work that the board has undertaken in 2025, quite significant really. Most of these reviews are actually published and on the Safeguarding Adults Board website, which Natalie will put a link into the chat. This session is being recorded and will be made available subsequently on the Safeguarding Adult Boards. What I ask for you to do within this session is to keep yourself on mute. And if you do have any questions throughout the session, if you could pop them in the chat, Natalie will be monitoring the chat and we will have some time at the end to go through any questions or queries that you might have. I'm just going to keep running through until I get to the end. This will be an overview of these cases. As you can see, there are quite a number of them. I'm not really going to do any of them true justice, but it's to give you a flavour of the work that's been undertaken and the resources that have been developed or updated as a result of the learning identified within these reviews. So if you are interested in finding out of any more detail on any of these reviews that are published, you can go onto the website and do that. Please, can you keep yourself on mute when you join? That'd be great. For the reviews, and there are a couple where I will say that they're not yet published. If you would like to have some more information about the unpublished reviews, then you can contact the board and request access or further information, and that request will be considered on an individualised basis. So without further ado, I'm going to move on to the first case, which is SAR Hazel. Now, this is quite an old case. Hazel was a 60-year-old lady who lived in a house where she had her own flat. It was a National Autistic Society placement. She'd lived on the site since she was 15 years old. She'd got a historical diagnosis of a learning disability, autism, and Bell's palsy, facial palsy. A significant symptom of Hazel's autism was anxiety, and she was driven to complete tasks and routines which she felt comforting. She was an outgoing and active and warm person who loved her family. She loved playing in water and swimming. She had a hot tub purchased for her to enjoy. She also benefited from sensory activities and attended the on-site day centre. Her family visited every couple of months, and Hazel also visited them and really enjoyed their company. She was assessed in 2015 for CHC funding, but wasn't found to be eligible, but had 10 hours of one-to-one support. And then in 2019, she was eligible for one-to-one on a 24-hour, 7-day-a-week circumstance. And so the CCG, as it was then, became commissioners of her care. She had a SALT plan in place for eating and drinking that specified that food should be provided in bite-sized pieces. There were a number of safeguarding concerns raised during the time frame of the review, which related to self-harm, financial abuse, and elements of organisational abuse. In 2019, July 2019, Hazel had her supper, which included a sandwich cut in half. She was noticed by one of her allocated one-to-one workers to be choking. First aid was commenced, an ambulance was called. She was transferred to hospital, but unfortunately she died 3 days later. So this is 2019, a significant time ago. Many changes have occurred since 2019, and we've had the impact of COVID. However, it is important to recognise that the review highlighted that Hazel's needs weren't being met. She had limited commissioner overview was very isolated, and actually there was poor evidence of activities or other social opportunities, and she didn't have a personalised care plan. Her family were keen for her to stay where she was living because they had a vested interest in the charity, and the fact that she was funded so far away from her ordinary place of residence mean that there was that limited oversight of her care on a day-to-day basis by the people commissioning and funding for her care. So the learning from SAR Hazel, if we move on to the next slide. So elements of the learning focused on some key areas. The first one was about oversight and escalation. It was important that actually there were clear escalation processes because in place, and we do have them now, because there were concerns around her quality, the quality of her care, the frequency and robustness of the reviews that were being undertaken. There was also concerns about how effective and timely the responses were from the placing authorities, and actually there needed to be strong escalation in place that protected people, particularly when they were placed out of area. There was something about autism training and best interests. So there was about the fact that autism training needed to be role specific, fit for purpose, making sure that people were clear that one size does not fit all, and that within all care that there should be the best interest of the person are paramount. And where there is a disagreement existing between what should be the best care for somebody, that mental capacity assessments are undertaken, that it's clear that there's been a best interest decision made and undertaken, and actually there's clear evidence when necessary that the Court of Protection has been considered where appropriate. Linked to that, there were issues around management of Hazel's physical health. There were some medication changes that had a significant impact on her well-being. There were multiple attempts made to reduce psychotropic medication following the STOMP process, and that was really good. But the providers were struggling with very complex behaviours as a result, potentially, of those medication changes, and the support that they were receiving and how they were escalating those concerns to commissioners and the local authority. And that led to sort of also how the local authority themselves were responding to safeguarding concerns submitted to them. It led to an increased involvement from multidisciplinary services. That was the behaviour support and the speech and language, and that was really, really good. However, there was a lack of involvement of family members within conversations about how to best support Hazel moving forwards. And there was also a lack of robust evidence around capacity assessments as well. And that's really, really important where somebody lacks capacity, or indeed there were disagreements about care decisions, which was the case for Hazel. Physical health checks also include those annual learning disability health checks that were really, really important and weren't always happening, because those learning disability health checks identify unmet physical and mental health needs. And unfortunately, we do know that people with learning disabilities experience poorer health outcomes. So it's really, really important that we try and identify those undiagnosed health issues, because they invariably can present as an increase in behaviours that challenge carers. Within the safeguarding and multi-agency working, it was identified that actually we need to have a better understanding of what legal frameworks can support us as practitioners. The safeguarding processes were recognised as needing to be clearer, and that there was a requirement to have clearer guidance for practitioners that support them when they were making decisions around care. And that links to sort of risk management and advocacy is about, who's got oversight when you're managing a situation or an individual whose behaviours are starting to challenge. How are you getting support from your management? Where is that organisational scrutiny? And how do we work with those people who are working on the front line to make sure that they feel better supported when situations are deteriorating? Linked to that as well is acknowledging the fact that even in Hazel's case, when she has family, she also has the right to advocacy, and advocacy wasn't identified either as something that would have helped Hazel through her pathway of care. Advocacy ensures that the person's voice is heard and protects their rights during the safeguarding process. So I suppose really from Hazel's case, it's important that we remember that everybody's care should be person-centred, and that person-centred care should be maintained regardless of the placement distance, that robust reviews must be undertaken where there are concerns or challenges against the care that's being provided, that the escalation happens effectively, and that oversight from management in relevant services is undertaken and robust. Consideration around capacity and best interests and what legal processes are out there to best support practitioners must be well known, excuse me, and must guide decisions. And it's really important that we implement effective multi-agency working and advocacy to protect those most vulnerable individuals. Excuse me a moment, I'm just going to cough. Sorry. So moving on to the self-neglect thematic review, this was a large piece of work undertaken by an independent author that looked at the cases of 6 individuals that had died over a period of 3 years. And it was felt that there were, despite their differences, albeit they were in their late 50s to late 70s, they died in a various settings, either in their own home or in hospital, and of various various health conditions. There was a key theme running throughout all of their circumstances in the fact that they experienced significant self-neglect, and there were concerns raised around how different agencies responded to, recognised and escalated the concerns around the conditions that these individuals were living in. So there were significant areas of learning, starting with assessment. So assessment was focusing on the fact that actually when any agency or practitioner undertook an assessment of an individual, that they were these assessments were assisting an individual to actually look at the person as a whole. Natalie, I wonder if you could move the slide on, please. Thank you. And actually, it's really important because people were tending to go in, practitioners were tending to go in and look at the individual only from the focus of the area of need that they were going in to assess, rather than actually looking at that individual as a whole, and then recognizing maybe where there were other elements that referrals needed to be made onto. For example, were there situations concerning their housing that needed escalation to other services, and therefore there was a need to review assessment processes across all services to ensure that holistic assessment took place. There were concerns around in 1 or 2 cases about an individual's safety, and this was particularly pertinent in the context of the local authority itself having no powers of entry and the high threshold for police powers of entry without warrant. And so assurance was also being sought about the introduction of the right care, right persons approach and its impact on safeguarding in this area. And that work is ongoing and being led by the Safeguarding Adult Board. There were a number of themes identified in relation to how safeguarding worked, i.e. the local authority safeguarding service, but also the pathways in place. So there was a need to look at safeguarding as a pathway, understanding developing a shared understanding across all agencies about the thresholds for recognising self-neglect, the use of common terminologies and risk assessment tools to facilitate better communication about risk for those individuals, There's also a need to look at the review of pathways that may be followed in a case of self-neglect, and that's been undertaken by the local authority recently, looking at those different pathways, which include multidisciplinary team meetings, multi-agency risk management meetings, and indeed the safeguarding Section 42 process, in order to make sure that there's a clear understanding about the difference between those different processes, and at what point you might move from a multidisciplinary meeting, for example, to a MARM meeting, or even into a safeguarding-led process, and how you escalate in those circumstances. And linked to that is also a plan to undertake an audit of not only triage decisions that are made when people make referrals into the local authority safeguarding service around self-neglect cases, but also to look at the work that the local authority undertakes when people are accepted under Section 42 to verify that appropriate risk management has resulted in a timely way. Linked to that also is making sure that practitioners know how they escalate. So if they're not happy about a decision that's been made in relation to safeguarding, that actually we promote the routes of escalation where professional differences remain unresolved or risk remains unmanaged. Excuse me. Moving on, there was also a recognition of advocacy about how and when advocacy services are offered, and when it's important that the Care Act functions of advocacy are pursued, such as the care and support needs assessment, care planning, and the Section 42 inquiry. And also to look at what your guidance is in your agency around the use of advocacy to make sure that individuals' views are heard and understood and taken into account when working with people who self-neglect. There was also plans to look at the current provision of advocacy as well, to make sure that what we've got in place works, and whether there's any need to change the commissioning practice for advocacy services moving forwards. There was also a recognition about how it can be very difficult to work with some people who self-neglect, who appear to be reluctant to engage, and the challenges around that. And we reflected as a system about how important it is to use professional curiosity when working with those people who appear reluctant to engage, to try and understand what their circumstances are, look at their life history, and explore what possible trauma they may have experienced that might be impacting on their ability to engage with services, but also impact on the way that they behave and the way that they self-neglect. And linked to that is also being very aware around people's mental health, and using outreach, assertive outreach mental health service when appropriate. Moving on, there was also learning around mental capacity. So there's various bits about work being undertaken by the Safeguarding Adult Board mental capacity subgroup, which has looked at undertaking an audit of practice in relation to mental capacity. That's to identify whether capacity is being routinely and appropriately considered in self-neglect cases. Some documentation is being developed to highlight how and when to secure expert advice. That's for assisting decision makers when carrying out capacity assessments in circumstances where specialist support would assist. For example, when we're working with somebody who has a loss of executive function, so they talk the talk but don't walk the walk, and they can be really difficult people to assess capacity around. There's also been ongoing work to look at the board's resources on mental capacity to make sure that there is information to support practitioners when carrying out mental capacity assessments routinely in situations where an individual's decision making puts them at extreme risk, exploring the concept of this executive function and its importance in enabling a person to keep themselves safe, and signs that might indicate when it's impaired and how to secure that expert advice. And also the very important bit about making clear records of how mental capacity has been addressed, because that has been picked up on numerous occasions around documentation, and whilst capacity has been queried, there's no evidence that clear capacity assessments have been undertaken. So there's work ongoing around how the board might raise awareness and practice in relation to mental capacity across the partnership. That's through provision of additional training. There's been the setting up of a new mentoring forum. And there's also other forms of practice development that are being explored, specifically in relation to mental capacity and cases of self-neglect. There were issues also relating to housing and accommodation resources, and that was a guidance recognising the fact that the local authority needed to do a review of accommodation, because there were challenges in the fact that there weren't the right forms of accommodation for those people at most significant risk. And there is an ongoing pattern of this about resource shortage, both locally and at a regional level. And that might mean that we need to do some work around escalation and make sure that commissioners are cited on this and are taking appropriate action. There was also the element around interagency working. So there's been some work undertaken by the Safeguarding Adult Board to look at how the multi-agency risk management pathway is being used. We considered whether there should be a single point of coordination, because that's been undertaken in other areas in the southwest, but actually we looked at it and decided that the current process we have in Somerset seems to be working quite well. We have reviewed the MARM guidance recently, and that's been updated not only from the learning from the self-neglect review, but also from other reviews that have been undertaken, and also through practitioner feedback. There is an expectation when undertaking or being involved in a MARM that the discussions and outcomes that are undertaken through that multidisciplinary case discussion are recorded in writing, and that there is clear timescales and responsibilities ascribed for required actions. And linked to that as well has been the review and relaunch of the Safeguarding Adult Board's Resolving Professional Differences protocol to help support people where there's a need to escalate a lack of engagement or a disagreement within that multidisciplinary working. And then finally, linked to the self-neglect thematic review, there was the element about looking about what training is out there. So there's a ongoing work to make sure that safeguarding training provided in all agencies actually has a focus on fire safety, and the importance of routine referral to the fire and rescue service for fire safety advice as a contribution to that risk management in self-neglect cases. There's also been a review of the self-neglect toolkit, which is available on the Safeguarding Adult Board, and that takes into account the learning from this thematic review, and has the inclusion of some case studies and other bite-sized self-neglect resources for use in team development. So you can take those things away, take them to your meetings and discuss on a more individualised basis. There's also a plan to monitor the use of the self-neglect toolkit moving forwards to see how it's being used, whether it's being used, and whether there's a value to that toolkit moving forwards. And then we move on to Juliet. So Juliet was a 63-year-old lady who had primarily been living at her partner's address for several years, although she did have her own tenancy as well in Taunton, but she didn't stay at the property very often. Partner agencies became concerned that Juliet was experiencing domestic abuse in the form of violence, which arose when she refused her partner's demands for sexual intercourse. There was also concern that Juliet was experiencing coercion and control, and that she was being financially exploited. This was complicated by the fact that Juliet had been dependent on alcohol for a number of years, which contributed to her level of self-neglect. And at times as well, the alcohol dependency was also perceived to be a barrier to adult social care, who acknowledged that she may have care and support needs. In addition to the alcohol dependence, she also experienced depression, was a heavy smoker, and was diagnosed with chronic obstructive pulmonary disease and was registered partly sighted. At one point, the police obtained a domestic violence protection order, which prevented her partner from abusing Juliet for a time. However, Juliet tended to gravitate back to him, and the risks which arose from her relationship with him continued, unfortunately, to her death. So the learning from the review, again, you're going to start to see some similar themes that get repeated throughout this session, but there was a multi-agency engagement. In this instance, there was the MARAC process, so the Multi-Agency Risk Assessment Conference, which is held for people who are considered to be in high-risk domestic abuse relationships. There was a need to consider the MARAC process and whether actually professionals meeting should have been held in more complex cases where somebody is particularly being referred back to MARAC on a number of occasions, and they are very complex. There's a need really to have a separate meeting to look holistically at what is happening for that person and not just consider the domestic abuse elements. The professional meetings would increase the likelihood of all relevant risks to the victim to be considered, and those that are impacting of those risks. The MARM process as well could have been utilised. So, that's intended to empower all the agencies in the management of risk to feel confident to instigate a multi-agency risk management meeting, again, for people with complex needs or circumstances. And the Somerset One Team process is a forum where concerns about individuals may be raised to agree the most appropriate pathway. But moving from that, there needs to be that multi-agency formal process and clear documentation about what's undertaken. And that didn't happen effectively in Juliet's case. There were decisions about Juliet's care again. So self-neglect. Research highlights the importance of undertaking a relational approach in order to help professionals find the person, and people struggle to do that with Juliet. They found the substance misuse a real challenge, and actually weren't aware that there are some good guidance out there about how you work with and manage chronic dependent drinkers. And there's a guidance document which I will reference at the end of this morning, but is also available on the board website, which is called is by the Safeguarding Vulnerable Dependent Drinkers document, which should be considered when working with people experiencing alcohol dependency. There's also a need to make sure that practitioners are considering referral to and seeking support from the Somerset Drugs and Alcohol Service for support. And there definitely was identified a need for practitioners to be more aware of how to seek support for perpetrators of domestic abuse and how to refer or encourage self-referral to the Engage programme. And that information is available on the Somerset Council Domestic Abuse pages. And finally, there was an issue about records management. So in primary care, it was important that there was a recognition that it's important that primary care have time dedicated to discuss patients, adult patients, where there are safeguarding concerns. Now, this is a practice that is good in lots of areas. It needs to be good in all areas. And actually, not only that time is allocated, but that there are robust records and that a register is kept to ensure that there's an ongoing monitoring of such cases. And also some guidance around what happens after a safeguarding referral, because you make a safeguarding referral, but actually agencies involved continue to manage the risk, and so therefore there's a recommendation that you plan a discussion to share and consider information across agencies to ensure that joined up approach, which is documented. And again, that could well be through utilisation of a MARM process. And then we move on to the homelessness thematic review. So this was these considered 3 individuals that Two, unfortunately, have now passed away, but one is currently receiving ongoing care in Somerset, that were experiencing multiple disadvantage and multiple exclusion homelessness. They had a number of issues that they were experiencing, homelessness being the key one, but also they had mental ill health. They were experiencing drug or alcohol dependencies. One or two of them had criminal justice involvement as well, and all of them had quite clearly defined histories of abuse and trauma. They were all at risk of or were experiencing self-neglect, and all faced risks of abuse and harm, including physical violence and exploitation. And one of them indeed also posed a risk to others, particularly through domestic abuse. They were all living with complex and overlapping risks related to their housing and social care needs. And it was recognised that understanding an individual's need for care and support must involve an understanding of the risk of not meeting relevant needs, as well as their exposure to external environmental risks, which should be dynamic and personal to the individual and relevant to the context of support they are accessing or seeking to access. So the learning from the thematic review, sort of summarised very, very briefly, were put into these 5 boxes. Next slide, please. So risk assessment and information sharing was a standard feature in the work that agencies did together with all 3 men. However, it was less clearly identified or understood how the risks were arrived at in a collaborative way, and then what action was taken when risks were understood differently by different partner agencies. And there were a number of times where the risks were perceived very differently by different agencies, and that was particularly at points of transition, such as prison discharge and eviction. 2 of the gentlemen lived with dual diagnosis needs, and although information identified during the review indicated that neither of them were in touch with formal clinical pathways during their death, it was recognised that the dual diagnosis structure locally is working well and embedded, but there are still challenges in enabling appropriate support for people in periods of transition. And actually, it's really important that we ensure that people living with dual diagnosis needs are not discharged from services when they move between settings and services, and that's a key area for improvement, particularly in relation to people leaving prison, and those times when accommodation status changes unexpectedly. All 3 of the men experienced transitions between hospital and or prison and the community during the review period. And the impact on these transitions on risk and need was significant for all of them, and in fact was identified to be a significant factor in both of the gentlemen's deaths. Learning from practice identifies that transitions between services and settings is a key opportunity for preventative safeguarding, and when these opportunities are missed, these transitions can then be experienced at cliff edges where support seems to disappear, and in its wake the risk of harm significantly increases. And the review identified that documentation showed good practice. It also highlighted that moves between accommodation placements, prison settings and hospital stays ultimately triggered homelessness, and appropriate services were not in place in a timely way. All 3 men also had contact with criminal justice agencies, primarily the police, due to challenging antisocial and unusual behaviour. Again, as well as specific incidences where police were involved, agencies also sort of described how their behaviour, which was not only antisocial but disruptive and sometimes aggressive, impacted on decisions being made about their housing, care and support, and also on attempts to build relationships. It was also recognised the police didn't raise formal safeguarding concerns about any of the three men, even though particularly one individual was recognised as a vulnerable adult when he was arrested. So there was a need to increase police involvement in a variety of meetings that are held to help this group of people, like the MARM meeting or the Creative Solutions panel. And then finally, there was the importance around an emphasis around relationships and support networks. And, you know, it's widely recognised that the involvement of family and friends is considered a key factor in successful care planning for adults with care and support needs. And whilst working with families is common when supporting children, older people and learning disabled adults, it's a significantly underdeveloped area of practice when we're working with people with facing multiple disadvantage. The majority of safeguarding adult reviews into the deaths of people experiencing homelessness and multiple disadvantage do not have the involvement of family and friends. And, you know, the practitioner event reflected the fact that the men didn't have many strong positive relationships in their lives. In fact, two of the individuals' family members were in touch with services and did care very deeply about them. But the issues that these two gentlemen lived with made sustaining positive relationships really difficult. So the recommendations linked to the homelessness review were put into sort of 4 broad categories. So we've got the direct practice. So there's this thing about strengthening legal literacy on housing and care. So the board is planning to seek assurance around the training that adult social care and housing staff receive in relation to legal literacy and housing, so that there's an improvement in the understanding of capacity, vulnerability, the use of the Care Act and the Housing Act 1966, and also the Homelessness Reduction Act powers of 2017 as well. There's also the plan that adult social care will promote the use of creative and lawful use of discretion to prevent abuse and neglect, particularly when working with people with neurodivergence and mental health or substance needs, and also an intention to improve practice on self-neglect and homelessness. There's already been a board-led review around the self-neglect guidance and training across the system, and we've widened that to make sure it reflects the needs of younger adults with complex overlapping needs, and also the development and dissemination of a practice briefing which clarifies expectation around mental capacities and decision making relating to homelessness. There's also been some work undertaken around, I think, family approach, and a learning event has already been held, and further ones may also be undertaken, which will have a focus on supporting family, friends and partners. And it's also been highlighted the importance of incorporating lived experience and the learning from the one team approach. And this is linked to a commitment to also encourage reflective practice across adult social care and NHS services to make sure that work and practitioners remains family focused. Relating to the organisational recommendations, so the safeguarding and homelessness work, so there's been a commitment from adult social care safeguarding to review data and practice relating to people experiencing homelessness. So that covers looking at customer services triages and how they filter homelessness related concerns and the impact of that, exploring a trusted referrer model to allow designated teams or professionals to possibly bypass triage where appropriate. Also to assess how homelessness related safeguarding concerns are recorded, monitored and quality assured, and review how concerns raised via multi-agency forums are prioritised and acted on. From a multi-agency perspective, again, it's about how we prevent that cliff edges through transitions. So it's exploring the establishment of a transitions panel to prevent homelessness and escalating the need for highly vulnerable people leaving prison, hospital or supported housing, or maybe look at how that might operate as a discrete panel or within an existing forum such as the Creative Solutions. And again, that's an ongoing piece of work. Again, it's about promoting MARM. So MARM is a reoccurrent theme. So that involves recirculating the protocol, seeking assurance of its use, making sure that MARM activity is recorded within local systems. So if you're undertaking MARM work, are you robustly recording that and can evidence that when asked from audit work that will be undertaken moving forwards. And again, re-emphasising the fact that MARM is for concerns below a Section 42 threshold, so it's not a replacement for safeguarding procedures, and understanding where it sits within that safeguarding pathways process. And then there's something about strengthening mental capacity assessment practice. So developing a clear understanding about roles and responsibility for capacity assessment in self-neglect and homelessness cases, providing guidance on fluctuating capacity as well as executive functioning, and again highlighting that resolving professional disagreement process, and then making sure that everybody is aware of that guidance, including frontline and voluntary sector practitioners. And finally, there was something about governance, and that's very much looking at inclusion health governance. So there's some assurance being sought from Somerset ICB on implementation of the NHS England Inclusion Health Framework. Having a named lead and having that lead within the board, and also possibly developing a county-wide inclusion health service map. Now that's going to be impacted by the current NHS reforms that are being undertaken, but it's certainly a piece of work that will be monitored and ensured moves forward despite that. There's something about strengthening engagement with prisons. So the independent chair was going to engage with local prison governors and also improve how we involve them in safeguarding, particularly at discharge planning for those highly vulnerable adults. There's something around prioritising homelessness within that safeguarding governance, making it a strategic priority within the board annual plan. Monitor implementation of the joint ministerial letter that was sent in May 2024, and seeking updates on homelessness governance, including the Homelessness Reduction Board. Finally, there's something around as well suicide prevention and people experiencing multiple disadvantage. So there's understanding how public health are progressing the 2024 to 2029 suicide prevention strategy within Somerset, with a focus on high-risk groups, including homelessness, addiction and neurodivergent adults, and making sure that it's aligned with wider safeguarding and risk management activity. Family H was focused on an older lady who had significant physical and mental health needs. She had multiple hospital admissions due to physical health issues. So that was heart failure, low blood sodium levels, and diabetic ketoacidosis. And the families also had concerns about her becoming muddled with short-term memory issues. She also needed help with insulin administration. It appears that care was provided by her son, a cousin, and also by a micro provider. However, circumstances, frequency, etc., remained uncertain. Ruby unfortunately died at the end of July in 2024, and a few days prior to her death, safeguarding concerns were raised by the paramedics, but also a family member, that Ruby's son was found drunk, having fallen down the stairs. It was also reported that he exhibited controlling behaviour, was not letting his mother downstairs. So a safeguarding referral was completed, and adult social care was contacted. The following day, Ruby missed an appointment at the GP practice, which resulted in a call to the police for a welfare check. It was reported that Grant had recently returned to England to live with Ruby whilst he was in the process of ongoing divorce proceedings. The micro provider also raised concerns, and Ruby had had several readmissions to hospital over the 4 to 6 months prior to her passing. When the police called, unfortunately, they found that both son and mother had passed away. So it was a very short period of time of review for this time. It was a really short time frame period for this review. However, there was still learning identified that was multi-agency. Firstly, it was about medication management. So the GP was hugely proactive in this area, and they recognised after reviewing their system for managing warfarin that they needed to implement some contingency plans to ensure that flags for missed INR appointments were checked, even if the responsible staff member was unavailable. They also implemented some additional checks, which was extremely good practice. And so what we've taken from this is to try and make sure that all practices have such a robust review process when people don't attend appointments. And I can't say enough how impressed we were by how proactive the practice were when they identified that this had become an issue. They were really recognised within the review as being really forward thinking. With the cognition and memory issues and hospital discharge, it was recognised that, again, there's a real importance about having thorough cognitive assessments, that there's clear communication and then coordinated care, particularly in relation to hospital discharge. It was recommended that acute hospital settings consider including reference to mental capacity in discharge summary, i.e. they should clearly state whether there was a reason to doubt a person's capacity at the point of discharge, to assist primary care colleagues in picking that up and exploring that in a more appropriate setting, i.e. the person's own home. There was the importance of monitoring skin integrity, ensuring that information about pressure wounds was communicated to the GP. It was noted that the district nurses should be involved in monitoring pressure rooms, and again, there was a recognition that actually when home visits are being made, that practitioners in that home environment should attempt to take a holistic approach to looking at the review of the health and well-being of the patients, and not just going in with a sort of tunnel vision of this is the work that I'm going in to do, and not considering that wider need for those individuals in that home environment. Safeguarding concerns. So around safeguarding concerns, it was the need for thorough assessments, clear communication and coordinated care to address the safeguarding issues. Practitioners should be clear about whether they're making a safeguarding referral or indeed they're actually requesting care and support. There seemed to be quite a bit of confusion about what practitioners were sometimes asking from the local authority. And indeed, the Safeguarding Adult Board is going to promote this message across all organisations about the clarity between the difference between a care and support needs request and a safeguarding referral. There was also a recognition that adult social care should provide feedback back to referrers, including GPs, on the outcomes and actions taken following a safeguarding referral, because that hadn't been the case in this situation. No surprises. MARMS, again, multi-agency risk management process was discussed again as a proactive approach to managing complex cases. Again, we're continuing to promote that and how it can be used along the same time as a Section 42. And then there was something about the son's role, recognising and understanding the importance of the carer's health and well-being, recognising that we can all recommend that a carer be offered an assessment to ensure that they are able to provide the necessary support. And that's a responsibility held across adult social care and health to move forwards to make sure that we are meeting the needs of the carers as well as those people that are vulnerable. David. So David was a chap born in 1971. He had a mild learning disability, epilepsy, and a long-standing left hemisphere brain lesion. He received specialist care moving from primary school. He was in a mainstream primary school, and then he moved into specialist secondary education. He lived with his parents throughout his life. And they moved a number of times, which unsettled him initially, but he adapted over time, and they relocated to Somerset in the 1990s. He had a wide range of interests. He loved classic cars, cricket, science fiction, Doctor Who, and Star Trek. He loved animals, he cared for a goldfish pond, and he enjoyed using computers and the internet. He had basic reading and writing skills. And although he wasn't a regular churchgoer, he took comfort in his belief in the afterlife, particularly when his mother died in October 2021. As an adult, he was generally considered to be able to make his own decisions, although his capacity could be affected during episodes of paranoid thinking. And they had discussed, the family had discussed future accommodation plans for him. He was registered with a GP and had annual health checks for people with learning disabilities, and was treated for epilepsy and other routine conditions. He was diagnosed with diabetes in 2019 and had his long-term epilepsy medication gradually withdrawn under medical supervision between January and July 2020. The COVID pandemics and lockdowns in 2020 significantly reduced David's social contact and increased his anxiety, disrupted his usual routines and his community interactions. Ultimately, his family was seeking a lot of help from services as David's distress increased, but which led ultimately to David having an accident at home where he sustained serious injuries. It's led to him being cared in hospital for a number of months until he died. And the coroner found that David had taken that actions deliberately with the intention of ending his life. So the learning from David, which is yet to be published, was a focus firstly on the mental distress that he experienced. He was in early 2021, he was often very distressed and worried. He was hurting himself and had thoughts of dying, which was worrying to everybody. At that point, David's mother was unwell, and his dad asked for help for NHS and social services. And they didn't feel that the withdrawal of medication was affecting his distress and worry. But there was no evidence of a comprehensive formulation, and assessment lacked follow-up. So there was a recognition that actually there needed to be a more robust approach to individuals who experience mental distress in this way. There was in the risk assessment and risk management, there was the risk of normalization. So he had ongoing suicidal behavior, which may have become desensitized within services, and there was insufficient safety planning for David. So despite repeated expressions of wanting to die, a more focused safety planning and direct home intervention didn't occur. So it's really important that local services and commissioners are going to consider whether mainstream and specialist psychological therapy offered to adults and with learning disabilities and their families needs review or recalibrating in relation to this practice evidence. There was also an issue around care coordination. So whilst it was recognised that David's needs were likely to be met by various specialists, the records review didn't actually clarify who, if anyone, was coordinating David's care, both within the community learning disability team, but also across the health and social care. There was no clear lead professional steering, planning and oversight. So it's really important that services consider how they communicate and understand a situation, and where they how they coordinate individuals' care, so it's steered appropriately across to all agencies. And again, that might be that you consider the complexity of an individual situation and convene a MARM or undertake a safeguarding referral dependent on the risk assessed. And then finally, is a thing about David's voice in the safeguarding, and also the use of advocacy. So there's quite a lot of information that was provided within the records submitted for the review that explained in quite a lot of detail what was happening to David and his family in their home. However, by and large, you don't hear David's own voice. And it's important to recognize that, you know, David was an adult with learning disabilities who's carried on living in his parental home, and he may well have found it quite difficult, understandably, to speak about their own hopes and wishes if they become accustomed to deferring to their family. So there was no consideration about independent advocacy for David and hearing his voice. And it re-emphasized the fact that, you know, making safeguarding personal as an approach within health and social care that should focus on person-led and outcomes focused, and engaging that person in the conversation about how to respond to their safeguarding situation. This didn't happen in David's case, and therefore, you know, you were going to have a limited ability to enhance his involvement and understand what his choice and provide him with control in that safeguarding process. And advocacy should always be considered for people to ensure that they understand what is happening and can express their wishes. And just two other reviews that haven't been published, partly because of the history involved within them, but still worth noting. So B and J were two gentlemen with learning disabilities living in Somerset County Council's supported living service. Between 96 and 2017. Jay had multiple disabilities, including blindness, non-verbal communication, constipation, and self-injurious behaviours. He lacked capacity in relation to his tenancy and likely lacked capacity in relation to his care and treatment decisions. He received regular manual interventions in relation to his constipation and specialist support from the Continence Service. B had a progressive brain disease, epilepsy, cognitive impairment, communication difficulties, severe learning disabilities, and required support with secretions through regular oral suctioning. B had some contact with mum, but COVID restrictions had an impact on that. He also had a specialist input from the SALT team. During 2020, a safeguarding report concluded that B's life had been compromised by substantial failings of the provider, and a safeguarding inquiry also concerned J, were concerned about his circumstances. There was a lack of evidence that family contacts were utilised, a lack of health histories, and it was recognised that knowing so little of someone whose support needs are so extensive impeded their support and capacity assessments. It was important that when support staff are learning to work with people whose behaviour is atypical, they may not be alert to the symptoms of illness or deteriorating health. And it's really difficult to achieve effective physical health care for people like J and B without some knowledge of their histories. And there was no history for these individuals. There was no detailed histories. So ultimately it meant that there was a missed opportunity, and recognise that actually Care Act assessments should be the starting point to gather this history. But I also it's a responsibility of all practitioners within assessments to try and capture that person's story. There was also an issue around healthcare encounters that appeared to be unplanned, that were in response to reviewing and ultimately safeguarding requirements. And actually, there was appeared to be a lack of understanding from primary care, because it actually recorded the supported living service as a nursing home, which means that there was a misunderstanding about the level of thoroughness and care and support that was being provided or was not being provided by that supported living. There was also a recognition that actually specialist skills were being provided by support workers with no healthcare oversight, which unfortunately led to abusive practices. But this has moved forwards now, and actually there is a really robust process in place led by CHC around how clinical training, when it's outsourced to supported living services, is managed and the oversight is retained by those clinical services. And again, unfortunately, in relation to decision making for both B and J, advocacy was not utilised. So their rights and interests were not central within any decision making that occurred. So the emphasis again is particularly on the local authority, but for all services, is to make sure that advocacy is a factor included when decision making is being made for those individuals, and actually it's also embedded in commissioning moving forwards, and is monitored to make sure that those people with relevant care and support needs do have advocacy support. C and K were both chaps with moderate learning disabilities, moderate or mild learning disabilities. C had challenges with, he lived in the community, but had challenges with attending appointments. He experienced financial abuse and was also at risk of self-neglect. Kay had a mild learning disability, had very simplistic language, and lived with his brother and father. He had significant osteoarthritis, which affected his mobility, and he wasn't on his GP's learning disability register, so he missed out on annual health checks. There was these two chaps were put together because there were some similarities around how agencies responded to their care and support needs. Again, an issue around capacity assessments, with a focus on understanding how to respond to executive functioning, and also how you respond as practitioners when there are different viewpoints held about somebody's capacity. An understanding is also about when you should consider the court of protection, and how it's important for professionals to ensure that their communication and documentation reflects all the relevant information, so that then can be considered in a capacity assessment. There's a need for the learning disability register it does now include more individuals, even those without a formal diagnosis, to make sure that there is broader support. There's a need for clearer and more accessible guidance on criteria for the inclusion on the learning disability register, and a more systematic approach to ensure all eligible people are included. So practitioners need to be aware of the support and services available to those people on the learning disability register and the pathways for that referral. And that might be, they could be eligible support from community teams for adults with learning disabilities. They need to be over the age of 18 and have a learning disability. And that would include an IQ of 70 or below, have a significant impairment in at least 2 areas of living skills, and a disability that occurred before or immediately after birth. No surprises, multi-agency collaboration, again recognising the need for effective multi-agency risk management meetings, highlighted as crucial. Organisations need to take responsibility to raise awareness of this as a process and provide training within their services to make sure that people are confident on initiating and carrying out a MARM meeting. And a link to that is making sure that practitioners ensure there's proper documentation and communication amongst all those agencies involved. And linked to that is making sure that where relevant, fire services are included, particularly in cases of hoarding where there are significant fire risks. And if there are any individual agency or practitioner feedback on how the MARM process works, that we encourage that feedback to be shared back to the board, because this is a process that should be owned by the frontline practitioners, and we're constantly reviewing it and evolving it to be as effective a system for those that need to use it on a day-to-day basis. Information systems is about making sure that people are aware, as I'm sure you all are, that we all have multiple different information systems across different organisations, and when you review or pull them together, they can provide a much better understanding of an individual's needs and risks. CIDR is the Somerset Integrated Digital e-Record. This is a shared care record system which can give an overview of health and social care information in one digital record. So it would be worth exploring whether you as an agency have access to that as a way of working out who is involved with that individual and then being able to get them involved in a multi-agency risk management meeting. And then finally, reasonable adjustments. Organisations need to make sure that training and understanding around reasonable adjustments, including using a digital flag, make sure that the individual's needs are recognised and accommodated across all services. The primary care liaison team works between learning disability specialist services and primary care to support reasonable adjustments and help individuals access services. And they are also involved in efforts to ensure that people on the LD register receive these annual health checks. So quite a lot of information within the different case studies. The final slide just provides a link to the relevant guidance that is on the Safeguarding Adult Board website. I've already referenced the MARM guidance quite a lot. There's a risk decision-making tool that helps practitioners decide whether what they are identifying actually warrants making a safeguarding referral, or actually whether you should undertake a MARM meeting first. There's a couple of documents that relate to vulnerable dependent drinkers and the legal powers about how you work to safeguard those people who are highly dependent. The resolving professional difference protocol is really important, and this is something that should be emphasised as something that we find time and again, that practitioners aren't escalating when things aren't working well between agencies, or where people get stuck with managing complex risk, and safeguarding is not the feedback is that the concerns don't reach the safeguarding threshold, and how do we move forwards to work with some people that are very, very complex. So it's really important that we signpost practitioners to the resolving professional differences as a protocol that can help in those situations of being stuck. The self-neglect toolkit, as I say, has been revised quite significantly and has some bite-sized guides which should be useful for practitioners. And again, it's available on the SARB website, as is a whole load of MCA related guidance and its own specific page on the Safeguarding Adult Board website. On the Somerset Council, there's some information for those people causing harm. So that links back to how do we work with people who are perpetrators of abuse? How do we support them as well? And then there's some briefing papers that are also going to be uploaded around how you work with people with learning disabilities, because as I say, a number of our reviews over the last year have involved supporting people with complex needs and learning disabilities. So I've reached the end of the presentation, which only leaves time now for any questions. As I say, it was a whistle-stop tour, and by no means does true justice to the level and depth of work that has been undertaken on all of these reviews. As I say, most of them are available on the Safeguarding Adult Board website. If you have a particular area of interest, you can go in and read either the practice briefing notes or indeed the detailed reports. And for those that are unpublished, you can seek further information if you feel it's relevant to your practice from the Safeguarding Adult Board manager, Natalie Green. Natalie's been monitoring the chat, so I'm just going to see if there are any specific questions that have been raised as part of my presentation.
We do have one. It's Pip has asked how primary care staff can check if a patient currently has advocacy support. Does it state that on CIDR?
I don't think it does. So I think the only way that they can do that is by contacting Swan Advocacy Direct.
I think Katie's actually on the call from Swan. I saw. May have dropped off by now. Yes, she has. Okay. We can check that though and get back to you on that one.
Yeah. Any other questions?
Sorry.
Oh, sorry.
There we go. Oh, Tanya, she's from Swan. So Tanya can come in there, please.
Yeah, it was just to say that I think it is something we've talked about in the past, that some agencies wanted like a tick box to say advocacy is involved, but I don't think it's ever been implemented. So as far as I know, the only way to check is to call us directly,
Yeah.
or email us directly to ask.
Okay, that's
Lovely.
great.
Thank you very much.
And we've got a question from Jane. If we struggle to get people to come to moms, what can we do? It can put people off doing them. Yes, it can. I would always proceed with holding the mom with the people that you can get to the meeting. I don't know whether there is a particular agency that you are struggling to get in attendance. I know that it has previously been mentioned that adult social care have been a bit difficult, but I think there are clearer pathways now on how to invite from adult social care. And we can clarify that and let you know, Jane. But also, the point is that if you are struggling to get people to attend, it's about escalating. So you can go to the line management within the service that you are trying to get to attend, and if they fail to respond, then you can either go to the ultimately come to the board or the ICB or senior people within adult social care to escalate as well in order to try and get support in getting the right people to the meeting. I hope that does that help. Great, thank you. Lovely. Okay. Any further questions? Matthew. You have to come off mute because I can't hear you.
Oh, can you hear me now? There we go.
Yes, I
Sorry.
can. Yes, that's fine.
You said about cider. I'm a care provider, so is that only accessible to adult social care in NHS?
I
Not
believe it's for government
sure.
organisations have
Mm,
access to it. So you would need to generally either go to the health provider or adult social care to basically dovetail in to share information.
Perfect. Thank
I
you very
mean,
much.
it doesn't give you health information. It just generally gives you a very brief overview and who might be involved working with that person, as then having a point of contact to go to come to a mom. So if you're looking at going, I think I need to hold a mom here, can you help me out? And you can go to either the local authority or a health practitioner to say, can you see who else I might need to invite? Because you should be working collaboratively together to help whoever it is that you're trying to manage risk around.
Yeah, that's perfect. Thank you very much.
Okay, you're welcome. Any other questions? Oh, sorry,
Sorry, Julia,
Natalie.
can I just add to that? If you are having difficulty finding out which agencies are involved or who you should be contacting with adult social care, because we do have a front door customer service system, you can go back to them and ask it to be escalated, and it will go directly to the team who are engaged with that individual. So that goes for safeguarding concerns as well. If you're not getting the feedback you require, you can reply to that and it will automatically then go to either the safeguarding triage and service manager or the localities team.
Okie dokie. Thanks, Nat. Any other questions? Okay. Well, thank you very much for joining. I hope you found it interesting. This presentation will be saved to the website in due course, and you can signpost to other practitioners to watch it if you think that it's been useful.
Have a great day, everybody.
Have a great day. Bye-bye. Sometimes whether people are paying attention and they've just got it going on in the background.
Yeah, because one, it says calling for Celine. I don't know why it says calling her at all. Something strange going on. And my other screen, which the PowerPoint was on, is just turned off completely. But it worked. Literally, as soon as I stopped sharing it, it just went black.
Oh, I had a massive coughing fit early on, and I thought I was going to lose my voice completely.
There we go. Stop recording. I can edit that.